The thing is, sepsis, what do we learn from the newer sepsis guidelines? Personally, I don't think we learn much from the guidelines at all. We have to make up our own minds. But having said that, we have to look at the guidelines and we have to really have our own judgment how we interpret all these guidelines. I'm not going to rattle out all the guidelines serially, the latest guidelines that have come up, but I'll just talk about certain aspects of guidelines which are newer, which are changed from before, and which needs my interpretation in certain ways. Sepsis itself was a Greek word meaning putrefaction, and it was first coined by Hippocrates. Everybody says that we have got so many definitions of sepsis from 1992, again in 2001 or 2002, second definition they came up with. Then it came again in 2014, the new definition of sepsis. Why do we need so many definitions? And is it that the sepsis is an entity which is very uncertain by itself that we need to change? It's not so. Definition should never be absolute. It should change with time and technology, as Socrates said, and that is very important. If we did not do that, we would not have been able to do transplants today, because the definition of that itself has changed, that enabled us to do organ donations. The earlier sepsis definition in 1992 was a very good definition. As a matter of fact, I still feel it's an excellent definition. It was very broad and very sensitive, but it did give a very good idea to the general practitioners, family physicians, to bring in more patients very early, and we could save more lives. So I don't think that it was really a very bad definition. Of course, it was not very specific like the newer definition, but it had its flaws, but it was a good definition. The most remarkable thing about that definition, Roger Bode was one of the authors of that definition, and the most remarkable thing about that definition was that it had a flood of hallmark papers coming out after that. As you can see, it's almost encompassed the whole spectrum of critical care, from appropriate antibiotics to hemodynamics to mechanical ventilation, early goal directed therapy by reverse, and going down and down right up to nutrition. So it really gave us the beginning of sepsis, as we really call, the critical care medicine as we really call. So I think so that was a very important definition at that time. The new definition is now, it was brought about in 2014 by the European Society of Intensive Care Medicine and the Society of Critical Care Medicine. It had a task force of 19 experts that included critical care experts, infectious diseases, surgeons, pulmonary specialists. The most important point in this, that it is a dysregulated host response, a life-threatening dysregulated host response. That was the most important. And how does it manifest? It manifests because it has got very high likelihood of adverse outcomes. And how do you correlate that? They felt the best way to correlate that is by showing that there is an organ dysfunction. And only organ dysfunction can tell you that this is a life-threatening dysregulated host response, unlike the first definition which only told you about SIRS. And infection, there should be an assumed or confirmed infection. So any assumed or confirmed infection with organ dysfunction, which was translated as SOFA score of 2 or more than 2. That is defined as sepsis with the new definition. They also came out at that same time as entity called QSOFA. That means if you want to pick up more cases outside the ICU, this was not a definition for people in the critical care, but outside the ICU, and they found that it has a great degree of sensitivity, but at the same time, it was specific for infection, and you could really pick up patients, and you can preempt patients getting a life-threatening entity, and you could transfer them to the ICU at an early stage, or you can look after them and preempt problems very early. It required 3 variables: the respiratory rate, systolic blood pressure, and altered sensorium. And with this, any 2 of this would constitute a QSOFA score. Why did they use a SOFA score? That was a very important thing. Why SOFA score of more than 2? Because they felt that what we wanted is to have to approximate with something which was already life-threatening. And SOFA 2 had a mortality of 10%, whereas STEMI, which is another life-threatening entity, has a mortality of 8.1%. So they felt that SOFA 2 would be the ideal level at which we should consider this as a life-threatening event. We use the difference between in septic shock. The definition of septic shock differs from the earlier definition only in one thing, that we have added lactate, serum lactate, as a third variable. The usual two are hypotension with fluid restriction, fluid resistance, with fluid resistance. But what was the need of adding this serum lactate, further serum lactate? As you can see, that adding this further serum lactate, it increased the mortality from below 30% to above 40%. But increasing the serum lactate levels more than from 2 to 4 did not make much of a difference. So this was the ideal way: hypotension with fluid resistance and serum lactate of 2, more than 2. And this was what was defined as septic shock. Of course, this definition had its own problems. And the major problem was that the task force itself was divided on 3 points. One of them was, the biggest reservation was on QSOFA, and they thought that this is a very unnecessary entity that is brought into it, and this should be disregarded. I mean, this should not be included at all, and they had marked reservations about QSOFA. The second part of it was that it was a more indicative of morbidity and mortality and less sensitive for infection. But the most important thing in which they differed was the lactate levels. Some of that felt that it was very a lot of resources had to be put in peripheral centers to include serum lactate every time that you wanted to define sepsis. But others felt that no, there are cryptic shocks which could be detected very easily if you add serum lactate to the definition. So there was a lot of difference between two groups in the task group itself. Now, we come to the Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock. This was published in 2016, but it was formulated in 2014 by the Intensive Care Medicine, by the societies concerned. Now, what is most important from earlier guidelines? The most important thing what they found, what you realize, is it is not based only on the evidence which we routinely use, that is random control trials or controlled trials or observed studies or expert opinions. That was not the only thing on which it was graded, the recommendation. It filtered the recommendation, or it filtered the evidence much more. It upgraded this or downgraded this evidence by including the risk of bias, the inconsistency in the papers that they read in meta-analysis, the imprecision of certain remarks that they made, and indiscretions used at a certain stages. After that, they tried to quantitate between the two. They balanced out the quality of evidence by working benefit versus the harm that it does. After that, the recommendation came, but that was not the end of it. Further, they filtered it down by saying, is it resource? Is it top heavy? Is it takes a lot of resources? And then it was graded down again. And if it was easier on the resources, then it was graded up. So it is really a filtered down evidence to a great extent. That's why this latest guidelines seem to be much more useful. Now, let's go to the first things in the guidelines, the important things of the guidelines, that they have made some changes or they require certain interpretation. According to this guidelines, the most important thing is that every time a patient comes in sepsis, you don't have to sit down and collect all the cultures, blood culture, culture from the catheter, culture from the urines, the tracheal cultures. They feel that you can get sometimes 2 different cultures from different places, and you'll be more confused. It's best, blood culture is always collected, but along with it, you only collect the culture where you clinically feel that is the source of sepsis, and use that. And then the other things are which 2 or more sets, aerobic and anaerobic. Yield does not improve with timing to temperature spikes. That is very important, but does not. Even today, I find that many of the doctors, residents, or even the nurses tell me there was no fever, so we did not take the blood culture. That is not necessary at all. Differential time to blood culture positivity. The data is inconsistent and not clear. So it is, according to the new guidelines, it is very ambiguous to use this thing, differential time to blood culture positivity. Okay, in the initial resuscitation, there was certain deviations from the early goal-directed therapy of reverse, which was published in New England Journal of Medicine in somewhere around 2002 or so. Initially, what he said, you don't have to go by CVP or anything of that sort. You just start a fixed fluid resuscitation, 30 ml per kilogram body weight with crystalloids. If monitoring has to be done, the best way is to find fluid responsiveness by using echocardiography or dynamic measures of fluid responsiveness. Norepinephrine dose titration is again important. It's not necessary that you have to keep it at 65 millimeters of mercury. That should be enough. In certain individuals, like patients who are hypertensive in the past, you may allow you must keep the borderline MAP, mean arterial blood pressure, to around 85 millimeters of mercury. And that is what's another remarkable thing about this definition. And serum lactate, more objective surrogate for tissue perfusion, and not SVO2 that we used to think about it, that it could be SVO2 or it could be lactate both in the earlier work of early goal-directed therapy. Recommendations: noradrenaline in hypotension after fluid resistance was the drug of choice. Vasopressin can be given. Main reason for vasopressin is not the first choice, please. The main reason for giving vasopressin is to lower the dosage of noradrenaline. If the noradrenaline dosage is going very high, to try to taper the noradrenaline down to help us to do that. But I will tell you one thing from practical experience: definitely be very careful about the dosage of vasopressin, and don't give it for more than 3 days. 3 days to the maximum. After that, I've seen gangrene occurring in peripheries very fast. You'll start seeing bluish red skin appearing very fast. So at third day, start thinking that can I reduce vasopressin somehow or the other, and try to do that as much as you can. Because if vasopressin hasn't helped you in 3 days, it's not going to help you by just continuing for a week or something like that. It will do more harm than good. Dobutamine is not the drug of choice in septic shock, except the patient has got a low cardiac output or he has got a cardiac event which is simultaneously going on. Steroids only if your vasopressors do not work. The steroids can be given, as we were told earlier. Paxil transfusion is not given in this recommendation. They do not recommend giving Paxil transfusion, as early goal-directed therapy had told us on the reverse paper. But transfusions can be given to patients who have got a very low hemoglobin or patients who have had hemorrhage. So there is no question about that. Those patients will receive transfusions. And of course, hetastarch in sepsis or septic shock is strongly contraindicated for its renal problems. As far as the biomarkers are concerned, procalcitonin is used to support de-escalation, never for diagnosis. Procalcitonin differentiating infection from non-infectious causes may be used, especially sometimes use it in ARDS patients. Other biomarkers that they have recommended are galactomannan and beta-glucan in our fungal infections. And most important, what they have stressed is no decision on initiating, altering or discontinuing antimicrobial therapy should be solely based on biomarkers or its changes. That's the most important recommendation in this. Empirical antibiotic selection in patients with sepsis, they have given it. So I have given you a little bit of a mnemonic so you can use it. So when you are selecting your empirical antibiotic, you use the mnemonic called sepsis. The site of infection is extremely important. That means you got a gallbladder lesion, you got meningitis, you got endocarditis. Depending on that, the appropriate antibiotic should be used. Environment: is it a community acquired infection? Is it a hospital acquired infection or healthcare acquired infection? Is it a ventilator associated pneumonia? So that is very important consideration. Previous antibiotics, if they have been used previously, especially within the last 3 months, these antibiotics as far as possible should be avoided. Severity of the illness makes a lot of things. If the patient is in septic shock, severe sepsis, then I think so appropriate antibiotics means the broad spectrum coverage has to be started immediately. You do not start with a lower rung antibiotic and start going up. You start with the highest broad spectrum antibiotics. You hit fast, hit hard as far as possible. Immunocompromised patients, same thing stands true, that you start giving higher antibiotics because this patient may not give you a second chance. They may start getting worse very fast. And of course, side effects are important when you are considering your antibiotics, like not giving aminoglycosides in patient who has got nephrotoxicity likewise. When to add antifungals empirically? All critically ill patients with uncontrolled fever or sepsis of greater than 7 days and have a negative blood culture and despite appropriate antibiotic and source control, this is despite appropriate antibiotics and source control, can be a group for thinking about fungal infection, especially if their age is more than 70, they are immunocompromised or other serious comorbidities exist. If there are 3 or more colonization sites, and if the patient is receiving total parenteral nutrition, is an abdominal surgery or central lines have been placed. The bone of contention remains till today with most of the intensivists, most of the surgeons against the infectious diseases group and against the people at in the laboratories, that de-escalation should be done very fast. The problem with de-escalation is that the very definition of de-escalation is used so differently when I was going through the papers that it was absolutely impossible to know whom and what about de-escalation. Broad to narrow was called de-escalation, multiple to targeted was called de-escalation, duration shortened was called de-escalation, IV to oral was called de-escalation, clinical improvement to discontinuation was called de-escalation, culture negative to narrow selection was called de-escalation. So one does not really understand by reading all these papers, the ambiguity was so great. A systemic review of antibiotic de-escalation, meta-analysis of 14 studies. This is the best meta-analysis that has been done. Instead of going through all the papers that I had tried to go through, in the end I found this meta-analysis most useful. And this shows that only one study in this whole group was a random control trial. That itself shows you that evidence is feeble. Whatever the microbiologist may tell you, evidence itself seems to be to a certain extent very feeble. Antibiotic de-escalation practice only in 35 to 60% of cases, even in patients where ADE was possible. That is, even in the study, they only practiced in 35 to 60%. Why so, if they were so confident about it? Marked comparability problems because of very variable definition, which I already told you. And it was commonly performed in patients with improving severity. If you are doing it in patients with improving severity, it does not make really much sense. And receiving very good broad spectrum multi-drug therapy. Further concluding remarks was AD did not reduce total duration of antimicrobial therapies, treatment or length of stay. Effects of AD on bacterial resistance have not been adequately investigated, only conjectured. Pooled study for mortality favored ADA group, but some study had big bias to accept as evidence. These were the concluding remarks of this paper. No study had adequately studied the impact of AD on unintended consequences. Only Leon et al. Showed frequency of superinfection and increased length of stay in the ADE group. So it was not a complete study that most of the people had done. So the final recommendation for AD would be, if there is a clinical progress and shock resolution, you can practice AD. Infection resolution is taking place and biomarkers show that the procal is decreasing, you can start doing your de-escalation. Lower severity of illness score, avoid in culture negative patients, and always start, this is obvious, the pivotal AMA, and narrow down that. That means if you are giving antibiotic for the same organ, say the patient is in shock and you are giving aminoglycides with meropenem, then you take out one of them. You don't have to give both of them. Companion AMA, omit it. Say you are giving it for also MRSA, something else, and it is not a MRSA problem. It is a gram negative. So obviously you take it out. And if there is unnecessary extended cover like antifungals and other things, you remove them. So this is what they advocate. And the time of ADA is very important. I'm so sorry. The time of ADA is very important because it will be more than 3 minutes. Time of ADA, they said, was you should start practicing ADA. The best results of ADA when they did it were between 4 to 5 days, not earlier than that. Anything done earlier than that did not show good results. Indications of non-invasive ventilation. They have come that indications are, I won't go into details, are one of these 5. Acute exacerbation of COPD, here BiPAP was most useful. Acute cardiogenic pulmonary edema, CPAP was most useful in these patients. Post-operative failures, immediate post-operative patient went into failure, you could try non-invasive ventilation. Immunocompromised patient with hypoxemia, of course, because you don't want to intubate these patients unnecessarily and create more harm. So you can start off with non-invasive ventilation. And surprisingly, in pneumonia, they felt that instead of NIV, high flow nasal oxygen was more helpful. As a matter of fact, the paper which I have quoted over here, which I have written over here, which I read it, and I myself could not understand the paper very well. It said that NIV in community-acquired pneumonia has high failure rate, which was a bit surprising. I was not too convinced by this paper, but I think I would recommend you all to read it and judge it for yourself. Lung protective ventilation, well, everybody knows there is no change about it. In ARDS, 6 ml per kilogram body weight is the tidal volume that you will always use, and this has been established. Now, there is an emerging evidence that it's not only in ARDS, but in all other patients. Because there is a lot of controversy on that. Many of these older teachers keep saying that, oh, you're talking about 6 ml, but that's only for ARDS. What about the other patients? Give 10 ml and 12 ml as we were giving previously. No, not so. There is enough evidence to show that all patients should receive 6 ml per kilogram body weight, irrespective of the fact they have got ARDS or not. Ultra protective ventilation in ARDS is a new thing, where instead of 6 ml, you give 3 ml per kilogram body weight, and for hypercapnia, you can use ECCO2 to remove the carbon dioxide if there is a lot of PCO2 going up. And this was one of the things that was. But it only benefits in patients who have a PA to PF ratio less than 150. Prone ventilation, I don't have to tell you more. It is, I think, one of the best therapies for ARDS if you can manage it. And I think usually we have excuses to say it's impossible, we cannot do it, turning is very difficult, patient cannot be fed, nurses. But if you have got the right resources, like at least 1:1 or 2:1 nursing ratio, and if you can do it, I think prone position to be done exactly 16 hours of prone position daily, and it should be continued. And here too, patients who benefited were those who had a PF ratio less than 150, and they should be continued till the PF ratio goes beyond 150. Aggressive lung recruitment, I won't go into details of it, but using PEEP, this is a new method of using PEEP and raising it by 2 minutes every time till you go to the 40, PEEP of 40 for 2 minutes and then bringing it down. The detail of it, I do not have the time to explain to you. ECMO or extracorporeal CO2 removal is a new thing. But tell you that theoretically it's a very good concept, to give extra oxygen if the patient cannot maintain his PF ratio at all. But up till now we were very cautious about it or chary about it because the technology was not so advanced. Today the technology is so good and it is so safe that people do try ECMO, though there is lack of clear evidence towards increased survival benefit and significant cost. However, much more important, as I told you, is the removal of ECCO2 in COPD patients, and especially if you are going to try giving ventilation at a very low tidal volume of 3 ml per kilogram body weight. Weaning, the recommendation is spontaneous breathing trials, either on straight away on TPs or using a CPAP. And they very strongly recommend that daily spontaneous breathing trial, and along with it, spontaneous awakening trials have to be given. Extubation, remember these 5 S's which they have stated. The patient should be for spontaneous breathing trial for at least 3 hours, because so often it happens that if you try to take it earlier, you may have all your parameters okay, but once again they get into problems. Decreased secretions should be there. No new shadows on X-ray should appear. Strength of breathing should be checked by forced vital capacity, and stamina of breathing should be checked by rapid shallow breathing index. Last slide, nutrition. I'm not going to go through nutrition. Most of it is now established. I think it is coming out of our years that you start with enteral nutrition. Yes, we start with enteral nutrition. It is absolutely perfect. But up till now people said no early parenteral nutrition. Taboo. This was unfortunately because the European Society of Parenteral and Enteral Nutrition, as well as the American Parenteral Nutrition plus Surviving Sepsis campaign, all said that early parenteral nutrition is dangerous, it increases mortality. However, they felt also that you should give trophic feeds to these patients because of a certain concept, which again is very theoretical, that there is a process called autophagy. In autophagy, they say autophagy is a process which protects your cells in a time of stress, but it acts best during fasting when you give the minimal feeds. So autophagy in the early stage is very important. However, there are people who also thought out of the box, and they said, what nonsense. When a patient is hypercatabolic at that stage, is severely sick, his scoring, his Apache scoring is 18, 20, 22. Are we going to not give him calories? Are we not going to give him nutrition? Because he is markedly hypercatabolic. How are we going to improve his lean body mass? So they said, no, in that case, we should try out early parental nutrition, give trophic feeds enterally, but try out early parental nutrition. So APNIC study, Swiss study, and also one study by Caesar, they all came out and they found surprisingly that the results were better. Mortality improved, and patients could take early parental nutrition. So in certain selected cases where patients are very hypercatabolic, you should not feel shy of giving early parental nutrition. And I think this is a new concept, and we should think about it very important. As far as the last thing is concerned, I'm not going to go to other things. They all remain the same. But immunonutrition, according to the new guidelines, is not really very useful. It should, as far as possibly, avoided, especially if the patient is very critically ill. Only thing left is glutamine. Glutamine is something which everybody wants to give. And so far, the studies have shown up and down, redox study, this study, they have shown that glutamine is beneficial, not beneficial. So in the end, a meta-analysis has been done by Chen in 2015 paper, in which he has come to a conclusion that it does not help any critically ill medical patient. It only helps critically ill surgical patient. It does not help from the mortality or morbidity point of view. It only helps from controlling the infection in surgical patient. And most important, if you can do blood levels, it's best of glutamine, or else you please give the appropriate dose of glutamine as recommended per kilogram body weight. If you give too little, there is no benefit. If you give more or a toxic dose, the patient's mortality increases. This is extremely important from the glutamine point of view. So with that, I thank you very much.